My name is Hussam Al Qaisi. I'm a specialist hematologist and a medical in Jordan University Hospital, also a medicine in the Department of Internal Medicine, bleeding and hematologic disorders. Bleeding and hematologic disorders are classified into being related to anemia and related. Necessary to limit coagulation to the site of injury. The hemostatic system is vital and is a vital protective mechanism that is responsible for preventing blood loss by sealing the sites of injury in the vascular system. However, hemostasis must be controlled so that blood does not coagulate within the vasculature and restrict normal blood flow. The endothelial cells of intact vessels prevent thrombus formation by secreting tissue plasminogen activator and by activating thrombin and adenosine diphosphate. Now, hemostasis proceeds into two phases, primary and secondary. Firstly, primary hemostasis begins immediately after endothelial disruption. It is characterized by vascular contraction, platelet adhesion, and formation of a soft aggregate plug. Primary hemostasis is short-lived, usually takes 6 hours. The immediate post-injury to vascular constriction abates quickly. If flow is allowed to increase, the soft plug could be sheared from the injured surface, possibly creating emboli. This figure represents primary hemostasis mechanisms, which begins with the injury and the contraction of the endothelium, reflex vasospasm, etc. Now, adhesions occur when circulating von Willebrand factor attaches to the subendothelium. Subsequently, glycoproteins on platelet surface adhere to sticky von Willebrand factor. Platelets collect across the injured surface. These platelets are then activated by contact collagen. Collagen activated platelets from pseudopods, which stretch out to cover the injured surface and bridge exposed fibers. The collagen activated platelet membranes expose receptors, which bind to circulating fibrinogen to their surfaces. Fibrinogen has many platelet binding sites. An aggregation of platelets and fibrinogen build up to form a soft plug. Platelet aggregation occurs in 20 seconds after injury. Now, with regards to secondary hemostasis, it is responsible for stabilizing the soft clot and maintaining vasoconstriction. Vasoconstriction is maintained by platelet secretion of serotonin, prostaglandin, and thromboxane. The soft plug is solidified through complex interaction between platelet membrane enzymes and coagulation factors. It leads to the formation of what we call the permanent plug. A secondary hemostasis involves the activation of the coagulation cascade. The cascade model consists of a sequence of steps where enzymes cleave proenzymes to generate the next enzyme in the cascade. It consists of extrinsic and intrinsic pathways, which merge together into the common pathway, leading to activation of thrombin. Thrombin cleaves fibrinogen into fibrin, which becomes cross-linked to form the permanent plug. Now, this is an overview of the coagulation cascade. We will go back to this later in the lecture. Now, what are the inhibitors of coagulation? Those are proteins that inhibit activated procoagulation enzymes and prevent excessive intravascular coagulation. Raised levels are not associated with bleeding. However, reduced levels may predispose to thrombosis. Those include antithrombin, protein C, protein S, and tissue factor pathway inhibitor. Now, the new understanding of coagulation incorporates the role of cells. It suggests that coagulation occurs in vivo in distinct overlapping phases. It requires the participation of two different cell types, platelets and tissue factor bearing cells. Now, all evidence to date indicates that the sole relevant initiator of coagulation in vivo is tissue factor. Cells expressing tissue factor are generally localized outside the vasculature, which prevents the initiation of coagulation under normal flow circumstances with an intact endothelium. When plasma comes into contact with tissue factor bearing cells, activated factor 7 makes a complex with exposed tissue factor. The tissue factor activated factor 7 complex activates more free factor 7 as well as factor 9 and factor 10, which in turn cleaves prothrombin to thrombin. So why do we have to know those facts to understand what we should look for? Now let's start in evaluating our patient. History is an essential part, and almost any patient with bleeding tendency will give a clue if history was taken properly. Previous history of bleeding episodes such as epistaxis, bruises, dental or gingival, excessive menstrual, post-surgical procedures, family history of bleeding tendencies, and history of consanguinity. يعني مهم كتير إنه نسأل المريض صار في أي نزيف قبل هيك، نزيف شديد، إمتى صار، وين صار، لو في أي حدا في العيلة عنده مشاكل في تخثر الدم أو عنده مشاكل نسفية، ولو الأب والأم أقارب. طيب, also when taking history, we should ask about the site of bleeding, duration of bleeding. يعني for example, if the bleeding dysfunction occurs immediately after injury, this suggests a defect in the primary hemostasis. If it occurs hours after the primary injury, this indicates a problem in secondary hemostasis. عشان هيك كنا لازم نعمل المقدمة الفسيولوجيك هاي اللي حكيناها. We should know the precipitating cause, if there is any previous history for surgeries, any family history for bleeding disorders, any systemic illnesses. For example, liver cirrhosis can increase the bleeding tendency because coagulation factors are synthesized in the liver. So, and liver cirrhosis may also cause splenomegaly, leading to peripheral platelet destruction, for example, leading to increased bleeding tendency, and many medications can affect coagulation. Now, what are the clinical features of bleeding? It depends, like the clinical features of bleeding would depend if this is a platelet disorder or a coagulation factor disorder. Platelet disorder usually are associated with the primary hemostasis. Coagulation factors are usually associated with the secondary hemostasis. Therefore, if you observe in the line before the last, bleeding after cuts or scratches is common with platelet disorders because it occurs immediately. Bleeding after scratches is less observed in coagulation factor disorders. And if you can observe with the coagulation factor disorders, it is delayed and is often severe. Once again, because it's related to secondary hemostasis, in comparison to platelet disorders, which is usually immediate and mild bleeding, the platelet disorder kind of bleeding is usually more pronounced in skin and mucous membranes, such as nose, gum, vagina, or the GI tract, while the deep bleeding is more pronounced in soft tissues. For example, in joints or muscles. يعني شو يعني بكون هيم arthrosis مثلا، بكون في عندنا muscle hematomas مرات. petechiae are common with platelet disorders. شو يعني petechiae؟ يعني زي هسه برجيكم إياها. Ecchymosis, bruising are usually small and superficial, with coagulation factor disorders are deep. Hemarthrosis or muscle bleeding is extremely rare with platelet disorders and is common with coagulation factor disorders. Now, screening tests, those are tests commonly requested for coagulation. Those include time, platelet function, prothrombin time, and partial thromboplastin time. Some of them measure the platelet role, where the platelets play a major role in primary. We know that platelets play a major role in primary hemostasis. Platelet malfunction may occur because of two major reasons: either low platelet count, a quantitative defect, which we call thrombocytopenia, or dysfunction in platelets though normal count, there is a qualitative defect which we call thrombasthenia. Now, platelet disorders result in defects involving primary hemostasis. Characteristic physical examination findings include petechiae, purpura, gingival bleeding, and epistaxis. The patient will have prolonged bleeding time, and platelet count may be decreased. The normal range is from 150,000 to 450,000. Other tests which can be used to assess platelet function is platelet aggregation and platelet function analyzer. Now, if you look on the figure on the right-hand side, those are called the petechiae, if you see, and this is the bruising. This is more common with platelet dysfunction. This is more common with coagulation factor dysfunction. And this bleeding is usually deep and more severe. Now, thrombocytopenia, it is defined as a platelet count of less than 150,000. Patients will complain of signs and symptoms of bleeding, mostly mucocutaneous bleeding. Lab tests will show prolonged bleeding time. PT and PTT will be normal. What can cause thrombocytopenia? Pseudothrombocytopenia, immune thrombocytopenic purpura, gestational thrombocytopenia, hypertensive disorders of pregnancy such as preeclampsia, drug-induced thrombocytopenia, TTP or thrombotic thrombocytopenic purpura, vitamin B12 deficiency, leukemias, and viral infections such as HIV. Now, what drugs are associated with thrombocytopenia? Quinidines, amiodarone, which is an antiarrhythmic, captopril, a medication used to treat hypertension, glibenclamide, antidiabetic, carbamazepine for seizures, cimetidine, an H2 blocker, tamoxifen, hormonal treatment for breast cancer, ranitidine, an H2 blocker used in treating gastric acidity, valproic acid, another antiepileptic, vancomycin, an antibiotic, tetracycline, an antibiotic, heparin is an anticoagulant, and various chemotherapeutic agents, chemotherapy. Now, thrombocytopenia, which is basically platelet dysfunction rather than decreased platelet count. The underlying etiology is an abnormally functioning platelets in spite of normal count. It can be caused by von Willebrand disease, which is the most common inherited bleeding disorder, or by uremia, by aspirin and NSAIDs, and other inherited causes such as Glanzmann's thrombocytopenia. Now, in absence of platelet qualitative disorder, most surgical procedures can be done safely if platelet count is above 50,000. In high-risk surgeries like neurosurgical surgeries, a platelet count of at least 100,000 is required. Now, what about screening tests? Let's start with the prothrombin time. Or the PT, it's derived measures of international normalized ratio, and those are measures of the extrinsic pathway of coagulation. It measures function of factor 7, 10, prothrombin, and fibrinogen, and it is used to check warfarin treatment if the blood is if the like if the anticoagulation is excessive, we would find a prolonged PTT and a prolonged INR. Also to check liver failure, to check vitamin K deficiency, and to check the IC as well. The partial thromboplastin time or activated partial thromboplastin time is a performance indicator measuring the efficacy of both intrinsic and common coagulation pathways. It detects decrease in factor 12, factor 11, factor 9, factor 8, antiphospholipids. It is used to check on heparin therapy, hemophilia A and B, and antiphospholipid syndrome. Now, this is figure of the coagulation cascade. This is the intrinsic pathway, extrinsic pathway. They both overlap in the common pathway, and this whole process is the hemostasis process. As you can see, an enzyme will activate a factor into an activated factor, which in turn will activate another factor into an activated factor, and so on and so on. And this will lead to finally a completion of the hemostasis process. We've mentioned all this cascade previously. Now, with regards to disseminated intravascular coagulopathy or coagulation, it's a very serious disease. يعني انا درست بمصر كانوا يحكوا دي اي سي، كانوا عشان يورجونا قديش هي خطيره كانوا يقولوا لنا death is coming، هيك يترجموا لنا اياها. يعني هي can occur after major burns, after severe sepsis, and other systemic disorders. It is a complex systemic thrombohemorrhagic disorder involving the generation of intravascular fibrin and consumption of procoagulants and platelets. The resultant clinical condition is characterized by intravascular coagulation and hemorrhage. It is always secondary to an underlying etiology and can be acute or chronic. Now, DIC is caused by widespread, uncontrolled, and ongoing activation of coagulation, leading to microvascular fibrin deposition, compromising blood supply to various organs. The ongoing coagulation process will consume clotting factors and platelets, leading to prolonged PT, PTT, and thrombocytopenia. Now, let's speak about hemophilia A and B. Basically, hemophilia A is factor 8 deficiency. Hemophilia B is factor 9 deficiency. Both are inherited in an X-linked recessive pattern. The incidence is 1 in every 10,000 males and 1 in 50,000 males for the hemophilia B. The severity is related to the factor level. If the factor level is less than 1%, this will lead to severe spontaneous bleeding. 1 to 5% moderate bleeding with moderate bleeding and bleeding with mild injury. And if the factor level is between 5 to 25% mild bleeding, bleeding with surgery or after trauma, both are related to coagulation factors. So it is soft tissue bleeding like hemarthrosis or hematomas, etc. Now, if you can take a look, on the left-hand side, this is a knee joint, which showed bleeding inside the knee, and this will lead to increased bleeding. This is a muscle with a hematoma underlying the skin, and it will look like this. And thank you very much for listening. Do you have any questions?
دكتور أنا عندي سؤال.
تفضلي.
إيش يعني سودو ثرومبوسايتوبينيا؟
ممتاز. مرات مثلا في ناس بيكون في عندهم مثلا psychiatric disorder, they would مثلا drink a lot of water, أو مثلا patient admitted و given enormous amounts of IV fluids. يعني من الآخر delusional. فهمتي علي كيف؟
أوكي، بس البليتلتس كاونت بيكون نورمال صح؟
لا، ممكن مثلا في حالات بالديكريس بليتلت كاونت اسمها مثلا اي تي بي من ثرومبوسايتوبينيا. ممكن يكون شيء يعني على الماشين تطلعهم انهم ديكريز، بس فعليا لما تقرايهم مانيوال على البلاد فيلم اندر مايكروسكوب بتلاقي بليتلت كلامبس. فممكن البليتلت كاونت، جواب على سؤالك، يكون نورمال، ممكن يكون ديكريز بس فانكشنالي مش ديكريز.
تمام، اوكي، شكرا.
العفو. حدا تاني عنده سؤال؟ ماشي، جود لك ويعطيكم الف عافيه.